Hi, I'm Ahmad Nazran, one of the urologists from University Malaya Medical Center. Welcome to the pre-course lectures for the UCAP 2025. So I'm tasked to give a lecture on the epidemiology, clinical presentation, risk stratification for treatment selection of urothelial carcinoma. So quite the handful, so let's get started. So the following are the slide contents. So I'm going to first go through a bit of introduction, epidemiology, clinical presentation, risk stratification, and then conclusion. So first, urothelium, as we know, lines the entire urinary tract from the calyces or vena pelvis of the kidneys to the urethra. And I'm sure later you'll hear the lecture from Dr. Chow regarding the special characteristics of this epithelial lining. So the urinary tract generally can be divided into the upper urinary tract and the lower urinary tract, which consists of the kidneys and the ureter on the upper part, as well as the bladder and urethra on the lower part. So as we know, bladder cancers are the most common neoplasm from this region, 90 to 95%, followed by UTUC, upper tract urothelial carcinoma, and urethral carcinoma, which although are there, are actually quite rare.
So we'll go through the epidemiology one by one, starting with the most common, which is bladder cancer. So from the Global Cancer Registry 2022, bladder cancer is the ninth most frequently diagnosed cancer, with approximately 600,000 new cases and 200,000 deaths occurring in a single year in 2022. As we know, partly due to increased risk behavior, incidence and mortality are higher in men, in whom the disease ranks as the sixth most common cancer and the ninth leading cause of cancer death. In Malaysia, based on the 2012 to 2016 National Registry, it used to be the 10th most common cancer in men, but thankfully it has since slipped out of that ranking, and we await the latest full registry of the 2021 Cancer Registry before we find out what's happening to bladder cancer in Malaysia. But from globally, more than 90% are aged more than 55, and the average age of diagnosis is 73. In terms of risk factors of bladder cancer, as we all know, tobacco accounts for 50% of cases. Okay, other things are occupational exposure to aromatic amines, polycyclic aromatic carbons, and chlorinated hydrocarbons, which are mainly in the dye industry. Okay, also other things, pelvic radiation from previous prostate cancer or rectal cancer can also lead to increased risk of bladder cancer, and certain drugs have been shown to have an increased risk, particularly cyclophosphamide. Regarding UTUC, the estimated incidence in Western population is 2 per 100,000. A bit closer to home, a study in Korea showed an age standardized rate of 0.88 per 100,000 population. The peak incidence is in the older age group, 70 to 90 years, and as same for bladder, UTUC is twice as common in men. Concurrent bladder cancer is present in 17% of UTUC cases, and even those following treatment of UTUC, the recurrence in the bladder is almost 1/3, and about a 3% chance of it occurring in the contralateral kidney. Risk factors are same as bladder. Also, tobacco exposure is very important. But the other famous thing for UTUC is this Aristolochia acid, which is can seen in the one of the Aristolochia species as shown in the picture. So this are quite interesting because it actually resulted first found in the Balkans due to agricultural contamination, where the seeds from this plant actually mix with the wheat and hence ingested by the people there and develop UTUC. And also closer to home, in the Chinese was found it was used in traditional medication, and now has been banned because of it's a well-known risk of cancer. Okay, in Taiwan, arsenic in drinking water also was shown to have increased risk of UTUC, and since they have actually done measures to reduce arsenic, actually the incidence has dropped in Taiwan. Alcohol and also genetic are important component, particularly the HNPCC or Lynch syndrome. Urethral cancer is quite rare. I'm not sure about the incidence in Malaysia, but in Europe they have prevalence about 4,000 cases with estimated annual incidence of 1.5 thousand. Again with a male preponderance. Okay, and the incidence peaks at the age of more than 75. Risk factors include recurrent UTI, urethral stricture and diverticular contributing to recurrent UTI, radiation, chronic urethritis from sexually transmitted infection, as well as lichen sclerosis. Clinical presentation, regardless of the position, any cancer of the urothelial lining can lead to hematuria. So this is the number one symptom, whether macroscopic or microscopic. Okay, urinary tract symptoms for those in the bladder, uh, depending on the position, can either cause storage or voiding symptoms. Urethral cancer can also cause voiding symptoms as well. Flank pain, particularly for UTUC. Pelvic pain, again for either bladder or urethral carcinoma. And for specific for urethral carcinoma, can also cause extra urethral mass, fistula, abscess formation, or dyspareunia in the females. Okay, and when the cancer is quite advanced, you can expect, of course, systemic symptoms.
Okay, now we talk about risk stratification. So as you know, for all cancers, generally risk stratification is based on the stage, which can be done according to TNM, but there are specific risk stratification tools. One is for non-muscle invasive bladder cancer, and the other one is for non-metastatic upper tract urothelial carcinoma. So we go through the one for NMIBC first. So you can divide into low risk, intermediate risk, high risk, and very high risk based on the grade as well as the T stage and presence or absence of CIS plus clinical risk factors which are stated on the right there, age more than 70, multiplicity of tumor as well as tumor size. So go through first low risk. Low risk is a primary, that means the first time done TURBT, single low grade tumor, okay, which is less than 3 cm diameter without CIS in a patient less than 70 years old. Okay, so quite mouthful there. Also, primary TA tumor without CIS with at most one of the additional clinical risk factors. Okay. Now we go to high risk, all T1 high grade without CIS, except those included in the very high risk group, you can see below, which is where they are not, depending on the actual T staging CIS as additional, depend on the number of risk factors, and also all CIS patients also considered high risk. So what does it mean? By high risk means we're talking about risk of progression. So for low risk, the risk of progression is almost negligible. Okay, of which a single post-operative installation of chemotherapy, Malaysia normally use mitomycin, is sufficient. High-risk patient, the risk of progression in 10 years is about 14%. So normally need to advise the patient for a full dose of intravesical BCG. Of course, 3 years means less risk of recurrence, but you of course have to balance that with the significant possible side effects with BCG. And of course, you can offer upfront immediate radical cystectomy. In very high risk disease, the risk is almost more than 50%, of which we should offer immediate radical cystectomy upfront. And if they refuse, then can offer intravesical BCG. For carcinoma, it's actually quite interesting in that in these patients, you cannot actually just do TRBT alone and think is sufficient. You must either offer either intravesical BCG or radical cystectomy. So you notice I haven't really talked so much about intermediate risk. Okay, so this is by the International Bladder Cancer Group, who uh, actually done this algorithm for intermediate risk. So intermediate risk, basically to keep it simple, is whatever that is not low risk or high risk. Okay, so based on 5 factors, again, multiplicity, early recurrence, frequent recurrence, tumor size, and failure of previous intravascular treatment, they actually divide them further into low, intermediate, and high risk. And the recommendation as such, generally for those which are low risk, you can just do TRBT or fulguration. For those with intermediate risk, you can again do the TRBT plus single instillation of post-operative chemotherapy, but you can also give induction and maintenance of chemotherapy, okay, or alternatively BCG for 1 year. Okay, for those with 3 or more risk factors, then you recommend BCG. So now we talk about risk stratification for non-metastatic UTUC. So the most important one are listed as a strong criteria here. So those high-grade cytology, high-grade US policy are very important criteria. So you have any one of these, it's already a high risk. Same for any presence of local invasion of CT and certain histological subtypes like micropapillary, squamous, or sarcomatous. All these will render them immediately high risk. Okay. So then there are some weak criteria here, like presence of multifocal disease, tumor size more than 2 cm or hydronephrosis. Previously, once any presence of this will render them as a high risk UTUC, but now based on guidelines, in the presence of low-grade tumor, they still can be, if you have any of these criteria, still be considered as low-grade. So that's why the most important things is the presence of, as mentioned, any of the strong criteria, then they will make them as a high-risk UTUC. Okay, and this is how the algorithm looks like for UTUC. So if you've got low risk, then it's when you can attempt kidney sparing surgery. Okay, either endoscopic, okay, but most of our percutaneous approach. For high risk, generally, the option is for radical nephrorectomy, whether you want to do open or laparoscopic, plus template lymphadenectomy. And then, of course, after that, we talk about adjuvant chemotherapy if indicated. So we've gone through introduction, epidemiology, clinical presentation, risk for NMIBC as well as UTUC. Okay. To conclude, urothelial cancer include in descending order of frequency, bladder cancer, UTUC, and urethral carcinoma. And incidence is increasing due to increased awareness and better access to investigation, particularly for microscopic hematuria. There are several important environmental risk factors, tobacco, chemicals for both bladder cancer and UTUC, and the thing is that this can be avoided and reduce the risk of bladder cancer. Gross hematuria is a very important red flag symptom that cannot be ignored, even if it's even microscopic also should not be involved. It should not be ignored. And risk stratification are available for NMIBC and non-metastatic UTUC, but this does not avoid the need for multidisciplinary team discussion as well as shared decision making with the patient. With that, I thank you and hope you enjoy the UCAP 2025.